Yeah, that's true. Subcommittee will reconvene. We left off with and I apologize, I thought an hour, but it ended up being more like an hour and 15 minutes, I guess. We heard from Dr. Skinner, so next is Dr. Castle.
Thank you, Chairman Pallone and Ranking Member Deal. I really appreciate the invitation to testify about approving healthcare value. My name is Christine Castle. I'm a board-certified internist and geriatrician and president of the American Board of Internal Medicine and ABIM Foundation. ABIM certifies about 1/3 of all practicing physicians in the United States. We are the largest of the 24 certifying boards that constitute the American Board of Medical Specialties. The certifying boards are independent not-profits that do not accept industry funding. We test, monitor, and certify that individual physician specialists have the knowledge and skills required to practice in their designated specialty. Because growing research demonstrates that higher standards for doctors means better quality for patients, board certification standards are recognized as an important component of the accountability frameworks of both public and private payers. So I very much appreciate the committee's leadership in examining the link between quality, cost, and value in our healthcare system. I want to make 3 points in my testimony today. First, while there are abundant opportunities to improve value across the healthcare system, the gap is widest and most distressing among those with multiple chronic conditions and those facing the end of life. Second, well-designed delivery system innovations can help to close that gap. And third, the success of delivery system innovations stands or falls in large part on the shoulders of highly trained and accountable physicians and teams of healthcare professionals. More than half of Americans have at least one chronic illness, and chronic diseases, as this committee knows, account for 1/3 of the years of potential life loss before age 65 and is the single biggest challenge in our growing elderly population. As we know, the problem is not the lack of spending. More than 75% of our $2 trillion healthcare bill is spent on chronic disease care. Too often, the problem is failure to deliver the right care at the right time and, importantly, to coordinate care across the complex care needs that involving multiple providers and settings in a patient-centered way. In fact, according to MedPAC, Medicare could save $12 billion a year by reducing unnecessary hospital readmissions, improving care transitions and care coordination, and enhancing primary care. A more patient-centered approach, especially to palliative and end-of-life care, could also contribute greater value to our healthcare system. Research shows that when patients' needs and preferences are the focus of care decisions, fewer resources are spent on aggressive and futile technical interventions. Patients receive more timely referrals to palliative and hospice care, and patients and their families have better quality of life in the days that remain. Payment reform needs to support the physician who has the skills, the evidence base, and the relationship to make this happen. As this committee also knows, the models to improve care for patients with chronic conditions and those at the end of life are now being developed and tested, and we're hearing about some of those today. In 2008, the American Board of Internal Medicine, along with 10 other specialties, began recognition of a new specialty of medicine in palliative and hospice care so that patients and payers could be more confident of the provider's skills. Patient-centered medical homes also hold out the potential to simultaneously reduce costs and improve quality. The concept promotes efficient use of office practice design as well as professional recognition and remuneration of the primary care physicians and geriatricians who are needed to manage and lead such practices. However, these very same professionals are in very short supply. A study last year showed that 2% of graduating medical students expressed interest in seeking careers in primary care internal medicine. Given this reality, medical homes and related models are going to need to make the very best use of the generalist physician skills that we can get to manage these complicated patients and to use the talent and experience of other members of the clinical team to support prevention and coordination. Those team skills are also not in common supply in our medical world or in our or taught well in our medical schools. The medical home model to date has focused mostly on system-level improvements like health information technology. These are necessary, but they are not sufficient. For the medical home concept to deliver on its promise, the designers have to create incentives for long-term relationships and effective utilization of care between the highest need patients and their physicians. Primary care and geriatric physicians will need the tools, both incentives and accountabilities, skills and experience to support care coordination beyond the confines of their practices. The 7 to 10 to 15 other specialists that the patient is also seeing also need incentives to share the information that they have with that medical home. And the medical home also needs two-way communication, not just with physician specialists, but with hospitals, nursing homes, rehab centers, and other community resources. Finally, I'd like to suggest that specialty board certification and maintenance of certification offers a way to enhance, improve the physician's skills and to ensure that they can continue to keep up to date to manage complex patients. What we require of physicians to maintain their certification includes regular formal skills testing, practice monitoring, and self-evaluation and quality improvement, including tests of diagnostic skills, clinical judgment, systems management, and the translation of medical knowledge and evidence into practice. All of these tools use National Quality Forum endorsed measures where they exist. Now, all leading health plans put a premium on physicians who participate in this process in their reward and recognition programs. We have also been involved recently in discussions with Senate staff to recognize this process of maintenance of certification in the pathways within the Medicare PQRI program, and we look forward to working with you and would ask the House leadership to give this idea similar consideration as a way of reducing the burden on doctors of redundant measurement requirements and a way of enhancing evidence-based approaches to setting levels for quality of care. So in conclusion, stronger infrastructure, better connectivity, and physician payment reform are all essential elements of a patient-centered medical home, as well as effective healthcare reform. But at the end of the day, my message to you is that the quality and value of healthcare for complex patients also rests in great part on the skills and judgment of the physician in relationship with the patient. Thank you very much.
Thank you, Dr. Castle. Dr. Goodman?
Thank you, Mr. Chairman. Members of the committee, I promise to stay on time. That's all right. All bureaucratic systems tend to show a similar pattern, whether it's the National Health Service in Britain, or Medicare in Canada, or the Texas public school system, or the U.S. healthcare system. In all of these systems, what you tend to find is a sea of mediocrity punctuated by little islands of excellence. In healthcare, people point out that if everyone in America went to the Mayo Clinic for his healthcare, we could cut the national healthcare bill by a fourth and quality would go up. If everyone went to the Intermountain Hospital System in Utah, we would cut spending by 1/3 and quality would go up. So invariably, in all these systems, people ask, well, why can't everybody else be like the islands of excellence? There are two characteristics of these islands. Number one, they tend to be randomly distributed, and that is because there's no reward for excellence and no penalty for mediocrity. And two, whatever makes them good is originating on the supply side of the market and not on the demand side. And the problem for us is that we don't understand why the good organizations are good. We don't know how to replicate them, and we don't have any model that tells us how to manipulate them. Now, despite this fact, there's huge interest in pay-for-performance systems in Washington and elsewhere around the country. And yet we've been doing this in education for almost 2 decades now. Certainly in my state, the state of Texas, we've been doing it, and I can't see that we've had any positive results. Now, if it's true that everything that anybody can point to that they like in healthcare is originating on the supply side of the market, and no one can point to any example where a demand-side reform is causing any commendable response, then it would seem to me that we ought to focus on how we get these kinds of supply-side changes, and I have 3 recommendations. First, we should stop penalizing what we like. When Mayo Clinic saves money for Medicare, it's losing money for itself. Same for Intermountain. When the Geisinger Health System, which was in the Washington Post just this week, offers a warranty on its heart surgery so that the buyer doesn't have to pay again if they screw up and there's a readmission to the hospital, Geisinger's saving money for Medicare, but it's losing money for itself. So we need to turn this around. Medicare ought to be willing to say, at least we'll pay 50 cents on the dollar when you're saving us money. So that's reform number 2. The second thing Medicare needs to do is tell all the other hospitals what it has done. We want other hospitals to know that we've rewarded innovations that improve quality and reduce costs, and then invite all those other hospitals not to copy what Geisinger has done, because we don't know that Geisinger is really doing it the best way, but to come forward with their own suggestions for repackaging and repricing their services. And number 3, we need to extend this offer to every hospital, every doctor, everybody on the provider side. Medicare ought to be open for business. It ought to be open to hear from any provider who suggests a different way of being paid, with 3 rules. Number 1, the cost to government cannot go up, the quality of care to the patient cannot go down, and they need to tell us 6 months out or 12 months out how we're going to measure all this to make sure we've abided by Rule 1 and 2. This is a totally different approach than the pay-for-performance approach. What I'm suggesting is let the supply side of the market, which knows far more than anybody on the buyer side, let them to decide and propose how we improve quality and reduce costs. And every doctor in America can think of ways that you could reduce costs and eliminate waste. It's just under the current system, they have no incentive to do so. Both in education and healthcare, we have the same fundamental problem. The entity that pays the bills is not the entity that benefits from the services. And that is the source of the inefficiency that we find. In healthcare, wherever there's not a third party, wherever there's no Medicare, no Blue Cross, no employer, things actually work pretty well. If we look at those markets like cosmetic surgery, LASIK surgery, the walk-in clinics and shopping malls, Teladoc, which does telephone consulting, the concierge docs, medical tourism, and all these markets where it's just patient and doctor and no third-party payer, you always find price transparency, you often find quality transparency, you have cost control, you frequently have electronic medical records, electronic prescribing. Doctors often are using telephone, email. In other words, doctors dealing with patients on their own tend to deal with patients the way other professionals, lawyers, engineers, accountants, and so forth, deal with their clients. We need to open up the supply side of the market and encourage this. This morning, Mr. Chairman, I've talked about freeing the doctor in this system. We also need to free the patient, and I've written about that elsewhere. Thank you.
Thank you, Dr. Goodman. Dr. Sigsbee?
Good morning, Mr. Chairman. Good morning, Mr. Chairman, Ranking Member Deal, and members of the committee. I'm here to talk about this morning, or actually now this afternoon, about how realigning incentives within the healthcare delivery system will lead to better quality medicine and will serve the Medicare population. As an introduction, I'm a practicing neurologist. I'm also medical director for a nearly 50-physician multi-specialty group and responsible for quality in that group. And I'm also incoming president of the president-elect of the American Academy of Neurology. Right now, as many have already pointed out this morning, we have misaligned incentives within the healthcare delivery system and payment structure. And in very real sense, we have procedure-centered care, not patient-centered care. And the focus should be on what's important for the patient, for the individual patient. I'm not suggesting that we cut payment for proceduralists, but what I am suggesting is that we need to adjust the payment system so we have a balanced workforce. There are certain consequences of the current incentives that have been reviewed before, and I'm sure you've heard testimony on, but at least from my own perspective as a neurologist, where we're responsible for taking care of diseases that are important to the Medicare population, such as Alzheimer's, ALS, Parkinson's, stroke, we're suffering the same workforce crisis that primary care is suffering. Also, intrinsic in the current fee schedule is actually not just a lack of incentive, but barriers to equality. Certainly, it's not at all valued by the payment structure. I have had physicians tell me that they did not want to get involved with quality efforts because it took them away from revenue-generated activities. And also, if you look at it, ambulatory quality systems are still in their infancy. Unlike hospital quality systems that have developed over the last several decades, we're still trying to figure it out. It takes a great deal of effort and energy to make these systems work, and they also are quite costly. Health information technology is an important tool. You also need healthcare coordinators and others that really make it work. PQRI, in my view, is an abject failure. Pay for performance, as it currently exists, does not encourage, actually is viewed as an ineffective quality measure, but quality can be done very effectively. And I'd like to give you at least my own personal story in this. I'm a member of a 3-physician neurology group. We have a joint commission stroke center at our hospital. Before we went through the certification process, we thought we were doing a great job of taking care of stroke patients until we actually started measuring what we're doing. And we were not doing as well as we thought or expected of ourselves. By placing the quality systems in place, by constantly monitoring, by developing a system of care that includes EMTs out in the field all the way through rehabilitation, we are taking very good care of those patients. We consistently exceed National Stroke Center benchmarks in terms of the quality of care that we provide. And it's that kind of in the community effort that's really required for effective health for quality measures. And it serves an example. And to really look at a payment structure, and at least in terms of the incentives, what's really important. And you've heard about accountable health care organizations, medical home. But what you're really trying to do is create a system where you're trying to incent the behaviors that are really important for patient care. Certainly productivity is important, not sort of the hamster mill of turning, but you need certainly enough physician work to have access for the Medicare population. Quality is critical. Patient satisfaction and really a good experience with the healthcare delivery system and confidence in the care that they're getting. But also you need to encourage the physicians to work on improving the systems of care. Care is no longer just one physician and one patient. It's across a whole system of care that, for the example of the stroke center, we have trained the EMTs so they can recognize stroke and deal with it appropriately. So you really have to have the whole system involved, and it has to be patient-centered care. And how do you create those incentives? There's a lot of discussion about healthcare delivery systems, but in fact, in the last 4 or 5 years, there's been a great deal of experience with creating physician compensation systems, which we're really talking about, and creating a balanced way of trying to incent physicians to do exactly the kinds of things that I'm talking about. And in fact, they've developed, and most places that now employ large groups of physicians have moved to what they call a blended compensation system, which includes both a salaried component as well as an at-risk component that can be determined not based on only productivity, but also on quality, patient satisfaction, and also what's termed citizenship, which is contributing to healthcare delivery systems. And no matter what system you involve, if you don't implement the proper incentives in that system, it will not really be an effective way and really encourage the kind of healthcare that we would like. So based on this experience, I'm recommending that no matter what system we move ahead with, that there be a blended payment structure that includes the right incentives, which not only will be good in terms of cost control, but will be good for patients. Thank you.
Thank you, Dr. Sigsbee. Mr. Smith?
Thank you, Mr. Chairman. It's a great pleasure to be with you again. First, let me hasten to say my views, my testimony are my own. They don't represent the position of my current and certainly not the position of my former employer, federal government. I do perhaps have a little bit different perspective than my colleagues here on the panel in terms of the experience of actually running these programs for the last 10 years or so of my life. It gives me perhaps a different perspective, seeing Medicare and Medicaid, two government health plans up close and personal. And one of the things that I think is striking to me is that they have to be part of the equation as well. Medicare and Medicaid account for approximately 45% of health care spending today. They're going to go up to 50%. So any idea that we can do this without involving reform in the entitlement programs would seem to me doesn't work. It's been 15 years since Washington tried this sweeping types of reform that's being currently discussed today. But in that time, states have been trying to do this. We have states as diverse as California, Massachusetts, Oregon, Tennessee, Hawaii, Maine, and Washington have all struggled with universal care. I would suggest that we learn from them since they've already tried it and see what lessons there are. And then certainly we have Medicaid itself, the experience of the last several years in dealing with the great growth in eligibility in Medicaid, et cetera. So there is a great deal to learn from. I think one of the things that also is the expectations. Right now, and I think in all of these states, the promise was being made to the people, not only those who were uninsured, but the people who were insured as well. The promise to them was this was going to be cheaper for everybody, and everybody's going to save. We're hearing that today. The President has made the promise that the average family is going to save $2,500 on average. That's $2 trillion over a 10-year period of time. In the last few weeks and months, we've made commitments to spend another $1 trillion over 10 years on health care. So it seems to me, right off the bat, we're $3 trillion apart from where the American people think we should be in terms of addressing the issues of health care. Again, I think we need to try the approach of lowering the cost first. Then it will become more attractive to people and that they will actually purchase it. I think the experience, especially in California and Tennessee, are very important lessons to the day. First, dealing with the issue of mandates. What does that do to the cost of care? I think the discussion in California was very reflective since we have that in recent memory. Where you started off with mandates, mandate participation, then you were mandating a particular type of coverage, then you were also mandating how much people were actually going to spend on it. You started a circular effect in which the mandates actually kept driving the price tag even higher yet. And I think that in itself contributed in a large part to why reform in California failed. Tennessee as well. Tennessee, the story of TennCare was not started as a health care issue. It was started as a budget issue. And accordingly, TennCare from the very beginning, I think, was crippled and doomed to failure. It took a lot of years. It spent a lot of money before the program itself was dramatically changed. So in terms of solutions, where do we look? From my way of thinking, look at what model is actually being very successful in getting people covered, although that in recent years we've had some struggle. But the dynamics, anyway, of employer-sponsored health insurance. What advantages do they have? First, they have the advantage of the tax code, in which individuals have a tax advantage to buy it through the employer. So level the playing field between individuals buying it on their own and individuals who are buying it through employers. Secondly, the dynamics of group purchasing. Individuals, when they go to the marketplace on their own, they're all on their own. They're all by themselves. Well, in group purchasing, in employer-sponsored, you're in a group. You get the discounts that is offered to the group, and you do not have the underwriting that goes on in the group setting. The entitlement reforms themselves, as I said, Medicare and Medicaid, in my mind, have to be a large part of it. My colleague at the end of the aisle talked earlier about the disparity in Medicare payments between Florida and hospitals. between Florida and San Francisco, but he didn't say why. The reason why is government actually interferes in the marketplace. We see time and time again in Medicare and in Medicaid where government artificially steps into the market, allows one hospital, for example, to leap 3 counties away so they get the higher reimbursement of an MSA from a higher payer. So we're interfering in the market all the time is so I think part of the solution is resisting that temptation. We have plenty of quality initiatives in Medicare. We've got, I think in many respects, the things that we're discussing today have been discussed for a long period of time. There's, in many respects, nothing new under the sun in types of those issues. But I think the one thing that would be particularly helpful is transparency. People should know what they're actually paying for, what they're actually buying. We tried this in the Deficit Reduction Act of 2005, where we tried to bring transparency to prescription drugs and ended up being sued by the pharmacy community who didn't want those drugs to become public. So, but transparency itself, I think, is a great advantage, a very important element that is absolutely missing. And finally, I think the long-term care in Medicaid, we are unnecessarily spending too much on long-term care for services that people don't really want. Talking to people with disabilities, they want to be in their own homes, in their own communities, not in institutional care. So we have to fix the FMAP in Medicaid to rebalance the system. Thank you very much.
Thank you, Mr. Smith. Dr. Avorn?
Mr. Chairman, members of the committee, thank you for the opportunity to testify today at this very important time for the nation's healthcare system. My name is Jerry Avorn. I'm a professor of medicine at Harvard Medical School, and for nearly 30 years, my research has focused on the effectiveness, safety, and affordability of prescription drugs and how those drugs are used by doctors and by patients. I've taught and practiced geriatrics and primary care internal medicine at several of the Harvard teaching hospitals since 1974, and I'm the author of a book, Powerful Medicines, which deals with many of these concepts. We doctors badly need more information about the drugs we prescribe. Our ability to take the best possible care of our patients is severely hampered by a lack of this information. There's also a need for our patients to be astute consumers of the medical choices available to them, and the nation increasingly expects those who pay for health care to be able to make the smartest possible choices. The information gap I will discuss today limits decision-making on all of these fronts. By history and by law, the FDA is not mandated to evaluate new drugs or devices against other treatment options. Its enabling legislation requires it to approve a drug for marketing if the manufacturer demonstrates effectiveness, which may simply mean that it works somewhat better than a dummy pill. But I've never had a patient say to me, Dr. Avorn, please prescribe me something that's a little better than nothing. Patients and doctors want to know the best treatment for a particular condition, but that isn't the evidence that the pre-approval testing system was ever designed to collect. Many observers feel that changing the legal standards for the drug approval process would be infeasible, and many others argue that it would be undesirable. In any case, once a product is marketed, important new information about its safety or effectiveness could be collected, which would be very important for doctors and patients to know about, but which is beyond the purview of the initial approval process itself. Once a new product is on the market, its manufacturer is likely to launch a massive sales campaign. The pharmaceutical industry spends much more of its revenues on marketing and on promotion than it does on research and development. The most costly new products are the ones that are most aggressively advertised to doctors and to patients, whether they represent a real advance or not. A time-tested generic drug may be the most effective treatment for conditions like high blood pressure or diabetes, and generics often have the most well-established safety records as well, and are likely to be the best value economically by a long shot. But the profit margins on generics are wafer thin, so their manufacturers don't have the resources to take out expensive ads on the evening news or to send perky salespeople to doctors' offices to offer us free meals and gifts to persuade us to prescribe those drugs. This skews the use of medications as well as other interventions toward the costliest choices, even when they are no better than the alternatives and may even be worse. Other perverse economic incentives can take hold when expensive treatments or tests, like chemotherapy or MRI testing, become profit centers of their own for the doctors who prescribe them or order them. The manufacturers of drugs and devices are investor-owned companies, not public health agencies. That's not a moral judgment, it's just an economic fact. Given these companies' responsibility to maximize return to their shareholders, it would be naive to expect these companies to be a good source to fund and disseminate studies that could sink one of their products. There's a clear and embarrassing track record of drug makers actually suppressing the results of research if it showed problems with their products. This has happened with antidepressants like Paxil, the cardiac surgery drug Trazolol, the cholesterol medication Baycol, and many others. And there are examples of this problem from nearly every field of medicine. At the beginning of this decade, my own research group wanted to study the apparent link between Vioxx and heart disease while that drug was still on the market. We had to seek funding for the research from its manufacturer, Merck, since there was so little federal support available to do this research. When our study found a clear link between Vioxx and heart attack, well over a year before it was taken off the market, Merck tried to persuade us to de-emphasize some key results, take a co-author off the paper, and then they dismissed the very methods that they had previously supported. Clearly, this is not the ideal way to fund studies of drug safety and comparative effectiveness. Until now, it has not been anyone's job to determine how well alternative treatments work and how safe they are compared to each other. We are often totally in the dark as doctors when we try to choose between several drugs for the same condition, since those studies are rarely done. Our patients probably think that we are playing with a fuller deck than we are. Perhaps members of Congress think so as well. We are not. As bad as the situation is for drugs, this informational gap is even worse for other kinds of healthcare intervention. A new medical device like a pacemaker or defibrillator or artificial hip mostly needs to show that it's not dangerous, not how well it works or whether it's better than existing products. And new surgical procedures or new imaging studies like MRIs and CAT scans don't have to show that they benefit patients at all. The worst consequence of this information deficit is that it prevents us from taking the best possible care of our patients. But at a time when the nation can't afford to provide health care for all of its citizens, and even people with insurance, as we heard earlier, have problems paying for that care, the economic aspect of this problem is also quite important. The U.S., as you heard earlier today, has per capita health care costs that are the highest in the world by a great deal. Yet our medical outcome data are overall no better than those of many other industrialized countries, and often much worse. In these rough economic times, when more and more people have to pay for health care out of pocket, high costs can mean no care at all. And for Medicare and Medicaid, not knowing which treatments work best and which have the best value and which are safest leads to patient outcomes that are worse than they need to be and costs that are increasingly unaffordable for the federal government and therefore the taxpayer as well as for the states. There is a solution to this problem. It is based on the same concept that underlies all of modern medicine, and it's the reason that we're not still using leeches and purgatives to treat most diseases. It is the idea that well-conducted scientific studies can show us which treatments work best for a given medical problem and are the safest. This information can be gathered through well-established methods of randomized trials as well as observational studies. The latter kind of research, which my group at Harvard performs, can review the clinical experiences of millions of people to learn how well similar patients did with different treatments. These kinds of observational studies can also enable us to ask questions about special subgroups of patients, such as minorities or children or the very old, the very groups that are often underrepresented or even excluded in the clinical trials that drug manufacturers perform to win FDA approval. This kind of research is a public good like clean air and good highways, which needs to be supported by government. The private sector is simply not going to do the research to identify drugs that are absurdly mispriced or toxic any better than the private sector was able to identify financial instruments that were absurdly mispriced or toxic. This kind of applied research is not something we should fold into the missions of the National Institutes of Health.
Dr. Aborn, I'm sorry.
Yes, sir.
But you're 2 minutes over, so if you could kind of summarize.
Okay. I will wrap it up. There's a way that we can get this information to physicians as well as make sure that it's out there in the literature. For a number of years, my colleagues and I have been doing a process called academic detailing, in which we bring information to doctors, much as sales reps do for the drug companies. The idea is that the states, in this case several states in the Northeast, support nurses, pharmacists to go to doctors' offices and bring information that is not about sales, but is just about the best possible way of taking care of patients. And we've shown over the years that this is a way of improving care and actually paying for the program's cost. In summary, there are ways in which we think that we as physicians can take better care of our patients and save money for the healthcare system at the same time. Senator Cole on the Senate side has introduced a bill to support this academic detailing outreach to doctors. I'm pleased that members of this committee, Representative Waxman and Pallone, have also introduced a bill that would do the same thing on the House side. The goal is to get us doctors the information we need to take better care of patients, improve those outcomes, and save money at the same time. Thank you.